the Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between.
Morning, George. It's Tuesday, and we have another podcast to record today.
Yes, today we have another spectacular, wonderful guest, Dr. Amanda Montalbano.
Hey.
The topic of discussion is going to be pediatric urgent care that we know something about and implementation sciences that I often struggle with. Take it away, Herb.
We're pleased to introduce Dr. Amanda Montalbano, a general pediatrician who has worn a variety of hats in her career: clinician, researcher, mom, wife, and advocate. Dr. Montalbano brings exceptional experience to pediatric urgent care, previously serving as Director of Scholarly Activities for the Division of Urgent Care at Kansas City's Children's Hospital, I think it's Mercy Hospital, and holding multiple national leadership positions in special interest groups for urgent care with the APA, the AP, and the Society of Pediatric Urgent Care. She holds a faculty position as a social professor at the University of Missouri, Kansas City, and research assistant professor at the University of Kansas Medical Center. Welcome, Amanda. It's a joy to have you on the podcast today.
Thank you guys so much for having me. This is fun.
We always ask, why did you choose pediatrics?
It was really more of a why not, to be honest. So when I was going through medical school, I liked everything, all of my rotations. Although I will say surgery was not my favorite. I tried to do as little OR time as possible, although it was my highest shelf score, probably because I was in the OR as possible. But at the end of it, I knew I had already had my NPH. I got my master's of public health between my second and third year. And I knew I didn't want to do clinical medicine forever. I love solving puzzles. I love making things better. And what better way to do that in medicine? But I knew eventually I wanted to move into research and advocacy. So I didn't want to spend a really long time in training being unhappy. It wasn't going to be like what I wanted to do for the rest of my life. So I sat down and I said, who was happy? I was like, you know what? The pediatric residents were pretty happy in comparison to their IM folks. So really I was like, if I do peds, I can go anywhere from there. And then by the end of my pediatric training, I had considered a couple fellowships and my husband was like, can we just be done? Can we just be done? And I found pediatric urgent care and it was a perfect fit for me.
Is your husband in healthcare? Or?
He is. He's an anesthesiologist.
Oh, Jesus. So
pediatric urgent care is a specialty, right? It's not a fellowship.
There are a couple fellowships, but they're not accredited yet. We're going through that process through the APA.
Oh, God, no, please. We don't need any more fellowships. It's a curse. You just make people waste 3 years of their life. If you can't do peds urgent care, if you did a 3-year residency, then you shouldn't be a pediatrician.
Yeah. Right now, they've pulled back. They were talking about doing 1-year fellowships. Then they talked about 6-month fellowships, and the APA said a 6-month fellowship isn't going to be enough. And so they pulled back and haven't been pursuing that as heavily. What we found with residents coming straight out of training, or even docs who think, oh, I've had my practice for 20 years, I'll go to urgent care and sunset my career. What we found is they didn't have the procedural skills. They didn't have especially for the new docs, the sick, not sick, home, not home, if not home, where. They couldn't tell that from the door, which is really important in urgent care. And some of the more technical things like reading your own x-rays, reading your own EKGs. So things that you could learn fairly quickly, but our problem is learning on the job when we're in a high acuity, high volume urgent care. It's hard to do on the job training for months on end. So that was the idea of, could we create a fellowship where we create space, where we create a financial structure around the loss of revenue, because it does slow us down when we are training those new docs in urgent care. So that was the thought.
I think it's Dr. Tu. He's on Long Island. He spearheaded a board on just diabetology.
Yeah.
And you can be either a pediatrician or an internal medicine or a family practice physician. and
Yes,
then you just take a test and you have to show that you practice that a lot.
that's me.
And then you can do that. I think that's a better thing. I always giggle when people say you need to read EKGs in pediatric urgent care. It's like, how often how often is an EKG really indicated?
It's about syncope is the one that I get every time. And then other than that, it just depends.
Yeah, because I see the urgent cares with adults or nurse practitioners or the ERs doing troponin and EKGs and adolescent chest pains. I'm like, are
No.
you nuts? What are you doing that for? And we see here it's a disaster.
If you're pulling troponins, you're not in the right place.
Well, EKGs on adolescent females with chest pain. Can you describe the chest pain? And then they're doing chest x-rays on every asthmatic still, which just
Oh,
drives me nuts. And you don't do chest x-rays on kids with asthma. They're always dirty. Just give them the bronchodilator and the steroid, and if they don't get better, have them follow up.
yeah.
But it's the world of medicine is so disjointed.
Yeah.
So much wasted time and energy and then cleaning up. So yeah, it's frustrating. So what does the practice of pediatrics look like in Kansas City?
Here in Kansas City, it's pretty well dominated by the tertiary children's hospital here. So our freestanding children's hospital has 2 campuses, 2 full hospital campuses, and then multiple satellite offices. We're the only tertiary children's hospital from Omaha to Oklahoma, Arkansas, and then Denver to St. Louis. So it's a really large catchment area. So we have people pouring in from all over coming to Kansas City. And then locally for general pediatricians, our hospital went out on a pretty large campaign over the last few years and had, I would say, 90% of the independent pediatric practices join as an affiliate practice, where they're still independent, but they're more closely tied to us. It helps them with some of their quality improvement work that's required and makes those sorts of things easier. It gives them access to some of our clinical practice guidelines, a direct line to some of our subspecialists. So it's pretty well tied. We have about 85% of the market, pediatric market here. HCA has moved on pediatrics here. We do have a large HCA hospital, but still they're trying to steal some of the subspecialists, but it's a pretty small portion of the population.
And when you say affiliate, does that mean that Mercy Hospital owns the practice?
They
Or
don't
the
own
clinic-
it. So they
clinically
basically
integrated
get a
network?
stamp of approval. So it says it's called a CMAP, so a Children's Mercy Affiliate Practice. And really
Okay.
it gives the practice access to some of the things on our back end, but they are still standalone, independent practices.
Okay. And so they're not negotiating contracts together. No, it's just a quality piece.
Pretty much, it's just a quality piece.
I hear the market is brutal there. The
Yeah.
ability to be fairly compensated for the work that you're doing is very hard.
Yes. Yeah, pediatrics do not pay well here in Kansas City. And honestly, because of the monopoly here, it's pretty hard to get competitive.
They do like a case rate or all inclusive where all the labs are included.
No. So the other part of this equation is the hospital system here also has a arm, I like to call it a shadow company, that takes care of about 250,000 Medicaid. So they contract and have a capitated and fee-for-service market on some of the capitated lives here in Kansas City. So when I say they dominate the market, they really have come at it from every angle and put their stamp on it.
And then Blue Cross Blue Shield has a huge penetration too there.
We do. We have a huge penetration of Blue Cross Blue Shield, especially on the Kansas side, not so much on the Missouri side.
Yeah. So it's like Rochester. There's 1.5 behemoth health systems that control everything, and one payer, Excellus. They control 70% of the Medicaid and insured market in Rochester.
Yeah.
So it's like they say, I'm going to pay you $5. That's it. They don't negotiate this. That's what you take it or you leave it.
Yeah.
But if you don't sign the contract with us, you're not going to have any business. See you later.
Yeah. And I don't know, some of the CMAPs may get some of the benefit from being an affiliate when it comes to negotiating contracts. I have not heard that from those practices. As far as I understood, it was more of a quality arrangement.
Equality. Yeah,
Mhm.
that's like Children's National Network here. It's a group purchasing organization and a quality organization, but they really don't have many quality incentive programs or fee for service negotiations with the payers. And what does your urgent care look like? Are you always at the same store or do you rotate?
Now that I'm very part-time, I'm technically more like a float. So we have 3 freestanding pediatric-only urgent cares that are spread throughout the metro. Kansas City sits on the state line between Kansas and Missouri. So we have hospitals on both sides of the state line, and we have satellites on both sides of the state line. So our 3 urgent cares see in total about 90 to 110,000 patients a year. So they see as much or more than our 2 emergency departments do together. They're open 365 days of the year, 10 hours a day, except for 3 holidays a year. So we see more patients than the ERs, and they're open 24/7.
Also, do they have an on-site laboratory?
Well, 2 of them do. 2 of them have an on-site laboratory that also serve as like a pop-off lab for our main campuses and some of the satellite practices around. And then our 3rd site, which luckily is like 4 minutes from my house, it doesn't have a standalone lab, but we have an iStat, which I don't trust or use, and then we have a CLIA waived labs there. So if you wanted to pull labs, you could and send it to our Kansas hospital, which is just down the street, but then you're waiting. Versus in the other urgent cares, you can order labs right then and there and have your results within 40 minutes or so.
I thought in order to be certified, you have to have a lab.
We have a lab, but it's mostly CLIA waived. Streps, flu.
I'm kidding. Not a
Correct.
moderate complexity. And you have an X-ray with an X-ray technician.
Yes, we all have X-ray with X-ray technicians.
And then you do the preliminary reading and then the radiology department reads it later? Or?
We have a fairly quick, all of our X-rays are ordered urgent, so we get placed right after the ER's any stat orders. It just goes into the hopper, and so we can wait on the reads, or most of them, if it's a chest X-ray, we're going to read it ourselves. If it's a long arm extremity or leg, we're probably going to read it ourselves. If it's an articulation, we may wait on the radiologist read unless it's really behind. So again, that's one of those things that as an urgentologist, you learn to do. Some of us are more comfortable doing it than others.
Yeah. And I was asking another question and I forgot. But yeah, it's nice to have the backup of the radiologist reading your X-rays.
Yeah.
That's really
And
nice.
if needed, we can have the tech also text the radiologist if we want to talk to the radiologist. They don't like talking to people, I feel, but
No.
sometimes it's necessary.
And how about bedside ultrasound? Have you guys started any bedside ultrasound?
No, we are actually in the process of really pulling back our scope. We have been minimizing our scope, I would say, ever since I even started over a decade ago. We will never, I should never say never, right? If you say never always, it's probably not true. I would say it is unlikely we will ever do bedside ultrasound. I know like Children's National, it's a huge push. That was part of their fellowship. They had an urgent care fellowship, was doing POCUS. But we only do plain films. We don't do cervical films. At our East location, we actually have MRI and T downstairs as well as ultrasound, but we don't use it as far as urgent care goes. We can't even put in those orders.
Oh, well. And why are you pulling back? Just because too much volume or?
Yeah, it's always a constant balance of acuity over volume. So the higher acuity, the less volume you're going to be able to put through. We already see an extremely high acuity. Our East location looks like a hospital, and you can see it from I-70. There also happens to be a big H sign because there is a full adult entire hospital to the north of I-70. So when people are driving, they can see us. It has an H. They're coming from the middle of Missouri, and they said, go to Children's Mercy, where their first stop. And East was my location for my first 10 years of my career. So we see status asthmaticus, we see blue limp babies being carried in, we see it all. I have literally seen it all come through urgent care. At our other sites here out south, it's a more affluent community. They're really well connected with their pediatricians, I would say, of our south location. And so with those, it's pretty bread and butter, other than they're trying to avoid the ER. There's our Kansas Pediatric Hospital is very, very close to our south site. And so they will attempt to not have to pay those ER copays and see if they can get by, because they know it's Children's Mercy. They know that they're seeing board certified pediatricians and pediatric nurse practitioners, but they're always going to push the limit of what we can do because they're avoiding the ER. And we really saw that kick up after COVID. People were really trying to avoid the ER. We saw the dip like everybody else did in the early days of COVID, but once people started getting sick again and things started opening up, our acuity went through the roof. And so it's really a push to try to pull back some of that acuity. And then I won't mention we're also intending to grow our urgent care division, but I'll leave that for another time. When it happens, I'll come back on and we'll talk about it.
Yeah. And then
What kind of model do you guys have? Is it physician run?
So all of our sites
Primarily?
require at least one MD or DO, one physician on the shift. We call that the doc of the day or the core doc. That person handles more any of the administrative stuff that goes on for the day. We don't have to carry forward any duties from our shift. We truly clock in and clock out from our shifts. So anything that was pending from the day or two before, as far as cultures, anything like that, the doc of the day handles. And we do that by site. And then if anything else comes out, if there's somebody comes in after closing and we have to offer them a medical screen, it usually reflects to that doctor. And just as the resource person, we try to not have the doc of the day also have learners. So we also have learners in all of our sites. We have medical students, which are from first and second year shadowing all the way to third and fourth year rotations. We have pediatric and family medicine residents. We have 3 medical schools in Kansas City, so there's a lot of learners for us, as well as we take PA students. So we have a lot of learners that are rotating through with us.
Who's actually seen the patients?
So we're also responsible for seeing at least 2 patients per hour is our goal. And then we have pediatric nurse practitioners as well. I have some amazing nurse practitioners in our division. We typically we try to staff based on volumes. We know most of that is a guessing game, but our east and north sites are a little bit busier than our south site. Part of that is just the physical plant of the building. Those buildings are larger, and so we have more rooms. And so at east, we may staff anywhere from 4 to 7 clinicians versus our south site, we can staff anywhere from 3 to 5 clinicians, but at least 1 doc, if not more.
So to be the doc of the day, you have to be pretty comfortable in your own skin.
Yeah. So being a core doc, you really need to be able to juggle multiple things at once.
And when you said 10 hours a day, what are the hours?
Everybody's open 10 to 8. We used to be noon to 10, and then we did a study on our volumes because there was a perception that there was a big line at the beginning of the day, and when we looked at our volumes, it took us a really long, 20% of our overall volumes were showing up in the first 2 hours of that 10-hour day. And
Yes.
so we trialed on the weekends to shift it from 10 to 8 to try to level load a little bit better, which helped a little bit. We also felt that the highest acuity tend to show up at the last part of the night, mostly croupers. And when we were giving a racemic for croup and we were keeping the facility open for hours on end, it was a money loser. And it's not really appropriate to have to transfer that patient to the ER. By moving those shifts of hours, we started to see a little bit of improvement with that. And then we started using a level loading system, like an online level loading system, and have relied really heavily on that post-COVID.
And what was your volume like between 8 and 10?
It's still busting out the seams.
You said you're now from 10 to 8, so you close at 8.
Yeah.
So that you let go of that 8 to 10 p.m. volume.
Yeah.
I think it's interesting, right? And why do the patients that are not coming from the rural communities not have access to their pediatricians between 10 and 3, say?
It was funny. I was listening to your last podcast, and is it that the phones are ringing off the hook at 8 a.m. and nobody can get through? And by the time they get through it, somebody calls them back at noon, they've already come to see us. A part of that, I think, is just the ease of being able to come and have an appointment without an appointment, to be seen when you need the care. I think that's really important. And our pediatricians are strapped in the community. Like, all our pediatricians have really full schedules. And we don't do any sort of child anything in urgent care. We're only acute care.
Yeah, you don't do sports physicals and that what I do per diems or locums, and what I find is they don't last very long, but some practices have taken the mantra of making sure everybody gets their well child exam done. And so they have 14 or 15 well child exams scheduled every day for each clinician. And there's absolutely no bandwidth to see a sick patient. It's just if you do 15 physicals, there's no, and especially if you're an older practice where you have I hate when I say this, but it's true. I'm in shock of the adolescent female physicals, because it's never hey, how are you, Amanda? It's, oh, I'm anxious about this, and their period isn't working, and they're worried about gaining too much weight, and it's not a hi, how are you? School's going great. Where are you going to go to college? Great, see you. No, it's a long conversation. The boys, we're just done. Is anything hurt? Nope.
They don't want to talk. The boys don't ever want to say anything. So
you need anything from me? Nope. Not even that sports physical sign? Oh.
Yeah. And I think that practices here also know that urgent care is an option, and how well we're staffed, how great the care we provide within our urgent care, and we communicate fairly well back to the pediatric practices. So I think that they're very comfortable with saying, just go to urgent care. It's now summer, so lots of injuries come through, and I find that it's just easier. They may send if they see an injury and they need an x-ray, they're actually sending them to the urgent care because that's where the nearest x-ray is. And then if it's positive, then they're going to flip it over to an urgent care visit anyway for us to splint it. So I think it's a matter of ease to just say, just go to urgent care. I know you're going to get great care there. I'll get the information back. It's really become a symbiotic relationship.
In the upper extremities, do you still use OCL, or do you have the fancier splints now that you can put on the kid quicker?
We now use, what is that called? What is the new one called? Somebody just texted it to me on our group thread. So there's now a new type of splint that serves as an ulnar gutter, a cock up, and I think it's called like an OTP or something.
Okay.
But basically it's like the old cock ups, but it's more shaped like an ulnar gutter. So you can use for everything but a thumb spica. So we use that a lot for our upper extremities, for fuchsias or buckle fractures, for boxer fractures, that sort of thing. But we also still have the good old orthoglass if we need to do a
the orthoglass is such a pain.
Oh, it's awful. It's awful.
But maybe you have technicians, you do so much volume of technicians doing it. But when you,
we don't do. I'm very blessed. I do none of my own splints. Our medical assistants do all of our own splints. We're just responsible for checking them and making sure that they're in correct anatomical position and they fit well.
It takes 10 minutes to do, and I'm sweating bullets doing it.
No.
But if you got technicians that do that, then it's great. And then the boots that my friend is an orthopedic surgeon with an ankle fellowship says that ankle orthopedic surgery becomes so dumb. If it hurts, put them on a boot.
Yeah, we try not to put sprains in boots, because typically if they go into a boot and they're not using it and then they get muscle atrophy, then they just re-roll it.
He says put everything in the boot.
Ugh.
You may want to x-ray or not. He says in the military they don't even x-ray it. Put them on a boot, send them to physical therapy for 2 weeks. If they still have pain, then x-ray it. And he says that works in the military, and they hardly ever miss a fracture that needed intervention. And it's pretty interesting because that's how they do in the military. Your ankle hurts, here's your boot, you go to physical therapy. If it's not better, then you go see the orthopedic.
But isn't it great? They can order physical therapy. As an urgent care doc, I can't order physical therapy because the insurance won't pay for it.
I
Who orders it?
What's that?
Who's supposed to order it then? Orthopedist?
The orthopedist or their primary.
Interesting.
Yeah. But we've had multiple come back. We now just don't even order them because most of them aren't covered if we order them.
What a loss, right?
Yeah. There's also one insurance that won't pay for Ciprodex unless it's ordered by an ENT doc.
So you've published a lot. What is your research interest?
When I came to really how I came into urgent care, like I said, I was interested in fellowships, probably because I like that research aspect of it. And again, I like puzzles. So when I was in residency, I started asking questions like, why do we get so many chest x-rays on these broncholytics? And I asked enough questions of enough people that I got connected with the Children's Hospital Association that's actually based out of Lenexa here in Kansas, one of the suburbs in Kansas City, and got put on a work group with a bunch of pediatric hospitalists around the country that looked at practice variation and guideline concordant care. And we worked on some benchmarking. And so I thought, great, I'll be a pediatric hospitalist for my life and work in this database with CHA, and it's going to be fulfilling. And I came to Kansas City because that's where my husband was at the time and interviewed, and urgent care said, I know you're interviewing with hospital medicine, but you come over here and interview with us. And urgent care in Omaha was pediatric urgent care in Omaha was very different than urgent care here in Kansas City. And so I was like, okay. And I loved it. They knew what to say to sell me. Credit to Tom Tryon for reading my dossier and knowing what to say. And he said, you can keep working with CHA, you can keep pumping out these fizz papers like every other hospitalist around the country, or you could come over to urgent care and play in data that nobody's ever touched. And I was like, ooh, I like that. I like being in gray. I like being the first. I like figuring out these puzzles. And so I came back, I did a rotation with them and really loved it. Urgent care here was very different than it was in Omaha. It was a lot higher acuity. I loved being able to work to the top of my license and then being able to pull the parachute and saying, no, this is too much, go to the ER. So it was a good fit for me. So I came down here, they offered me a small startup package for research. And so I was able to start looking at care variation and where kids are seeking care and realized there isn't a FIDS database for pediatric urgent care. So we had our own internal numbers, which were huge, right? We've been seeing almost 100,000 patients a year for over a decade within our pediatric urgent care system. But as I started reaching out around the country and asking other pediatric urgent cares, I realized if you've seen one pediatric urgent care, you've seen one pediatric urgent care. There was no sort of standardization across the board. And I thought, how the heck are patients and families supposed to figure out where to triage themselves if they never know what they're going to get when they walk through the door? So I started my 7-year campaign of studying freestanding pediatric urgent cares around the country and collecting data and building a database. I'm very proud of this. Organization of Urgent Care Health database.
Okay.
That's right. The OUCH database. And we started looking at standardizing what people could expect when they were going to visit a freestanding pediatric urgent care. So what are the standards? What can they expect to do? And from that, the CDC said, oh, you have this really large network of pediatric urgent cares, and we're interested in antibiotic stewardship. Would you think about leading an antibiotic stewardship collaborative? So I did that for 2 years. And while really we were doing a great job for the most part in antibiotic stewardship within pediatric urgent cares, we did decrease inappropriate antibiotics by about 20% and sustained that for over a year. And then the Urgent Care Association actually took that and applied it to general urgent cares, which has been a huge help because that's really where we were seeing kids come in with a red ear. They're like, here's 14 days of Septineer. It was just like,
or worse, here's a CPAC for you.
Yeah. Or yeah. Or yeah.
Or you got a call. Here's a CPAC and prednisone for you.
Yes. So hopefully that work was impactful by it. But at that time, I had really been playing in the data for a while. I had built the database. And to be fully transparent, I was getting a little burnout at that point in my career. And there was an opportunity to join our patient and family engagement team as the first medical director. And I was lucky enough that they chose me from their pool of applicants. And it was really bucket filling. It's really what I needed in my life at that time. And I got to play in new data. We had...
Data nerd.
I'm a data nerd. I am such a data nerd. Thank you for understanding me.
I love that.
In
I
my
love
advice.
that. Nerd.
Yes.
And
So
I was
we...
very curious about one of your studies. I'm sorry,
Yeah.
I'm talking over you, but
No.
because here's a question I had. You looked at 4 million claims data on Medicaid patients. And one of the things that you found out is that white kids on Medicaid visit the urgent cares more than non-white kids. Is that because, and this doesn't apply to Virginia, I'll tell you how Virginia is in a second, but is that because there are more rural white kids and the minorities are more urban?
You're close. You're on the right track. So yes. If you look at the
Let me tell you in
distribution...
Virginia, before you answer that question, Virginia, if you go to the southwest side where they used to do all the coal mining, it is literally all white. On Medicaid, it's a very poor area of the state. But if you go to the southeastern part or the eastern part near the coast, there's a lot of African Americans. And on the lower part near North Carolina, there's a lot of Spanish immigrants. Near the cities, like here in Virginia, and in Northern Virginia suburbs of DC, you got the very wealthy suburbs. And then the not well-to-do suburbs where you have basically like the clinics I help, you don't see a white family all day long.
Yeah.
It's all colored and 85% Medicaid.
That's urban.
It's suburban, but like exterior suburbs, because the interior suburbs are too expensive for quote unquote the working class. It's ridiculous. I think like the county where I live, the median income is $180,000 a year. And like 60 to 70% of the adults in the county have a college degree or better.
Yeah.
So that's not the national average.
No.
And I'm not the closest suburb. Loudoun is a little removed from DC. If you go into Fairfax, it's even more. And if you go into Arlington and Alexandria, because people can hop on the train and be at DC in 5 minutes, it's more affluent, more expensive, and more educated. So
DC is a little bit of a outlier, I would say, than the vast majority of the other countries. The other thing is with the Medicaid data set, it's a national representation, but it's only like 11 or 13 states, and they don't tell you which states it is.
Okay.
So that's a caveat, right?
Okay.
Trash in, trash out. So you have to know what the data, the limitations of the data is. But you're really close. So the vast majority of non-white individuals are going to be urban for the most part. If you look at the national population distribution, and that the suburbs are going to have the largest white population, and that's also the largest population of urgent cares, especially at the time that study covered. You're looking at, I think that was back like 2011 to 14 or 15. So back then, urgent cares were pretty much suburban for the most part, because that was where the best payment was. Right? They're gonna go where the best payer mix is, and so I think that's why you saw more white kids utilizing urgent care. But the other thing that you saw with that is that we had this theory that urgent care, or we wanted to know if the null hypothesis was right. If kids are going to urgent care, does it replace them going to see their PCP? That was like the big hubbub back when I started in urgent care. Everybody hated urgent care because it was a dot in the box and you got terrible care and it replaced the relationship with the medical home. And really what we saw was kids who used urgent care just were higher utilizers of medical care in general. So it wasn't really replacing anything. It just increased access. And whether that access was necessary or not, we couldn't tell.
Yeah, more anxiety-driven care. But you also...
Back in the day of when Dr. Bravo was a young doctor, we used to take calls. And if the kid had an ear infection, We would say, take some Motrin, talk them down off the ledge.
See
I'll
me
see you in the office in the morning.
Yeah.
Now it's the immediate gratification that it can wait till tomorrow to see Dr. Herb. It's 5 o'clock at night, 6 o'clock at night. They can. And so that increases the cost of care. Now, do you know why? I've observed this. People always ask, the Latino population here in Long Island, they tend to use the emergency room a lot.
Yeah.
You know why? I figured it out.
What's that?
I didn't do any studies. A lot of the Latino women, they feel that they can't, they all speak English, but they feel like they can't. So the husband is working because he's doing whatever he's doing. He's working until 6 o'clock. And Dr. Bravo, who speaks Spanish, his office closes at 5. So they're going to come home. The kid's been sick with a fever all day and they want to see a doctor. I can't wait tomorrow to see Dr. Bravo in his office. So I cannot take a day off of work. So I'm going to go to the emergency room. Whether it needed to go to the emergency room, did it not need to go to the emergency room? I don't know, but.
So the Amanda's study also looked at there, right? Like the kids that frequented the ER more often had less access to primary care.
Correct.
Is that right? Did I get that right from your study?
I don't know if that was the paper that we looked at it. I think Lindsay's paper was probably looked at this more accurately. But again, it has to do with that distribution of where care is, right? So if you're living in an urban city center, it's going to be easier to get to an ER than it is to get to an urgent care or your PCP.
Correct.
So it's unfortunately where you live dictates what care is easiest to access. That's just the way it is. And in your case, George, and it may be a transportation issue. The husband or the man in the house who's going to work is the one with the vehicle to get to work, and maybe the mom's been at home all day without transportation. We see that a lot. Everything is going to be multifactorial, but I think a lot of it is dictated by where you live. And what we have seen, I haven't studied this, but there's been a couple papers published in the Journal of Urgent Care Medicine that patients will choose convenience over relationship almost every time. So they're going to go and seek care at the most convenient location.
So this is very interesting because when I did own the urgent care, I had these, so the urgent care is in Loudoun County. So it was, and I did not accept Medicaid. And basically I didn't accept Medicaid because it's such a problem getting them to a specialist. And if you're not part of a health system, then you can't get them because the specialist won't take Medicaid.
Wow.
You know, like the orthopedic surgeons in town, they won't touch Medicaid with a 10-foot pole. So you're there in the urgent care by yourself. You're not part of the health system. You got a kid with a fracture that you want to follow it up. And they call the children's hospital and they're like, yeah, the next appointment's 3 weeks from today for orthopedics. And forget if you're trying to get it in the summer when they're doing all the spinal rods for scoliosis, it may be 6 weeks because they're in the OR every day putting rods in. And so I'm like, I don't want that liability. And but I asked a couple of the parents that seemed to be there every time the kid had a cold. You got a great doctor, George. Why do you can see me so often? And the moms universally said the same thing. Look, Dr. Bravo, I have 3 kids.
Yeah.
And my husband works all day. If I bring the other 2 kids along, I can't have a conversation with you. Because they're all over the place and they drive me nuts. I wait for my husband to get home. I leave the 2 kids that are not sick home, and I bring the sick one to see you, and then I can have a conversation, and then it's great. And if I need follow-up, I got Dr. George to see the next day. But I get a conversation. It's just about managing the family. And so, I never thought about it that way. I guess you're right.
Yeah.
It's that opportunity. Anyhow, what do you mean by implementation science and efficiency, which I found that very interesting. That's one of your core values.
Yeah. Like I said, I'm a data nerd. And when I see data, I start to put it into, I organize it. So implementation science really set well with me. I had done research. I had looked at all this variation in care. And Esther Cho and I did a paper together. And I remember being on a call with the co-author group. And this is great, We can look and we can find and we can report all day long, but what are we going to do about it? And at the time I was like, how dare you? That's so important. Looking at data and finding patterns is so important. And 5 years later, I'm like, I feel her so much right now. What are we going to do about this? And UMKC had a certificate program on implementation and dissemination science. And I was like, okay, let me see what this all is all about. And it was exactly what I was looking for. And it's not just what I had felt in the hospital before is, okay, somebody has a great idea and we're just going to try it out and see what happens over the next year. And then maybe by then we'll remember to look and see if it made any difference. Like, it didn't really feel like anybody planned anything or organized it in a way. Implementation dissemination science is really connecting the science, the systems, and the people to affect real-world change. And the way that you know that it affects real-world change is that you have to be able to measure it. And I think that's one thing when people think about, oh, we're going to try this. How are you going to know if it worked or not? You really have to know how to build these measures in order to be able to know if it's going to work or not. And it's all about small tests of change, doing little things at a time and seeing, does this little thing make a difference? And as you add those little things over and over again, it should compound. How implementation science is different than, I would say, Lean, Six Sigma, DAMAC, any of the other ones, is that it also puts tests of change into a cultural context, right? You can't just take one intervention and say, oh, it was successful here, we're going to plug and play in this other place, because maybe that other place is completely different. It's not going to work there. So that's where implementation science really wraps the intervention with things that are going to support it, because you've already sought out what are going to be the barriers to implementing and what are going to be the facilitators. And so you can really gain momentum to make sure that happens.
And how do you measure that? Because to be able to measure that, you have to measure how people feel, right? So if you tell me I'm supposed to use, this gets under George's skin. He's a big proponent of ambient AI virtual scribes. Okay. And half of his clinicians won't use it.
Okay.
And the question is, it's not because they're stupid, because they're pediatricians. It's not because they're stubborn, because some of them are young, some of them are not so young. So how do you measure why they're not doing it? So qualitative analysis, right? You got to do an interview and find out this is what's stopping this subset of clinicians from adopting this, because it makes total sense from what everybody's showing right now, that it reduces the amount of time you spend in front of the computer, that patients are happier, you go home on time, it should decrease burnout. All of that is true. But for some reason, there's a subset of people who won't do it.
Yeah, so there's a little bit of toolbox too. It's not, you don't necessarily, again, it's going to be probably multifactorial. Everybody is probably going to have a different reason. And so one of the tools in the toolbox I would pull out are the 5 whys. So when you go to somebody who's resistant, you continue to cascade the whys until you get to the actual root cause. So let me give you an example of how this could work.
Yes.
So we were seeing, let's say we have 10 patients in a room at a time, right? And it's during flu season, strep season, whatever it is. And we're finding that it's taking forever to get our strep test results. Like, it should be 15 minutes. Like, we should not be 45 minutes in a room waiting on a strep test result. So we started to ask why. We found out that the tech in the lab was batching all of the strep tests together. Why are you batching it? Well, because otherwise where we're doing the strep tests are really far from where the samples come in. And so I'm walking back and forth in the lab 20 times an hour. And I'm like, okay, why are the strep tests that are super frequent all the way across the lab? It's because this other machine needs to be closer. Okay, why does that other machine need to be closer? Because the samples for that I have to get from upstairs and so you have to keep asking those questions. When it came down to it, we just moved the strep machine. And all of a sudden, our efficiency went through the roof. So that's an example of 5 whys. You can't just start with one question. You really have to keep going down the rabbit hole until you figure out what is the real barrier here. And part of it was not all the strep tests were coming down. Some of them were walking down. So some of it was standardization of care as well. But that's one tool. Again, you're not going to, that's what I love about implementation science is there's all these tools in the toolbox. You have to know which one to apply in order to get the biggest outcome. So in that, I'm not measuring how the tech feels or how the docs feel about having delayed. That was just the impetus of doing the study. But what we were able to do was, what was the time from ordering the test to getting the test results? We actually time marked on one of the things I love to do is benchmarking and time marking. And so from the time that the test was ordered to the sample was taken to the result to discharge, right? Like where in that time can we crunch? What is the non-value add time that we could decrease?
That
Different tools in the toolbox.
right, but that's a simple test and a tech, not a physician. What do you do when the physician personality is the impetus?
Yeah.
No, if you think back in the years of the EHR is probably a good thing. The resistance that came with that was remarkable. I'm seeing the resistance on AI scribing to be even worse.
Let's just say that I'm one of those resistant physicians.
Huh?
That we don't have the opportunity yet, so I can just put it out there. Let's say I was the holdout. And so why are you a holdout? The AI scribe can create my note, but I'm going to have to go back through, read it, reorganize it, edit it. It would just be faster if I typed it from the beginning.
I heard that answer before, and I can categorically tell you that the AI scribe writes really well. And you don't have to go inside, and every now and again it'll have a hallucination, but most 95% of the time it's perfect.
Yeah.
You have to deal with the 5% of the time.
Yeah. And so the other thing I see frequently is we'll just tell people how much better it is. And then they should just adopt it, right? Like the intervention is always education. And like you guys said, the docs aren't stupid. They're really smart people. It's not you can't educate them to be on the other side of the line. You have to, again, maybe it's a small test of change. Maybe saying, I'm going to decrease your schedule for 2 days. And so we'll let you use it for these 2 days. You tell me what your issues were over those 2 days, and we can work on that. And on the back end, I'm measuring and I'm going to compare it to your historical time. So you can, because physicians are very data driven, but they're huge data doubters.
Yes, they are.
So I was medical director of patient family engagement. This was my big learning moment. They are huge data doubters because their patients are always different, right? My patients are different. That data over there doesn't apply to me because I'm different. I'm special. My patients are different.
No, the interesting thing is I do tell them that it is better. It's life altering. Can't you see that my notes are all closed at the end of the day? It's a better note. I am happier. I go home on time and you don't. And the billing is better and it brings income to the office. Now, very interesting story. Dr. Bravo was one of the naysayers at the very beginning, as was I. Because when one of the other doctors, Dr. Igor, introduced me to it, he said, George, take a look. I said, I know the templates. It works fine. I am the best one. I wrote it. Lots and lots of stories. Second day, he tells me about it. Igor, it's just going to slow me down. I got medical students that are scribing for me anyway. Third day, another kind of story. And then on the fourth day, he said, George, you should try it. Do you want to go through life knowing that I knew something that you didn't? That's what triggered me. And he was right. Dr. Bravo, I tried to tell him and show him. He didn't want, was very resistant. He complained about notes and things like that. I tried to do all the other stuff. I almost bullied him into doing it. And now he's a believer. But these are not normal behaviors.
There's always going to be the adopters, the fast adopters, there's going to be that middle section, and then there's going to be the resistant. And it's honestly, people want to cling to the fast adopters and fold them up and say, look at the shiny perfection that they're having. But honestly, if you look at the resistors and you use the tools in the implementation toolbox to figure out the barriers,
Yeah.
that's where the learnings are. Because showing them the shiny thing didn't get them to start in the beginning. And part of it is familiarity, and part of it is the repeat exposure. That's part of the therapy, if you will. But really understanding what the barriers are and being able to ease those barriers, that's what's going to get that, at least the middle ship. And then, like you said, we're working on an 80-20 rule. If we can be successful 80% of the time, then we'll work on that 20% little by little.
Yeah. I did use one tricky way of getting people to adopt to it, was you give them the AI Scribe, pay for it and all, let them use it, and then take it away and let them go back to the old ways. Sometimes that works.
Yeah.
So
Change.
So George is not being fair because he doesn't like to ask why. He just likes to tell people what to do.
No, Igor tells people what to do.
No,
I-
you do.
I
So-
try to convince you.
No, you
agree.
don't. You bullied me into it, and you didn't listen to my why. My why is very simple.
Oh, why? What was it?
I'm a per diem doctor. I could be one clinic one week, another clinic another week, and I got to figure how this works in different settings. And if the owner buys into it or not, the owner may say, I don't want you to use that. And it may be the best thing ever, but if the owner says no, they own the clinic. I go in there and I use the methods they want. Some people do hemoglobin screening at 1, others do it at 2, others do it at 3. I don't know there's a right or a wrong answer. As long as it gets done some point, it's okay. But I can't go into each clinic that I go into and say, no, that whole thing is wrong. Everybody should be screened for anemia at 9 months. That's when the dip happens. So you're going to have to do it my way. They'd be like, don't come back. Yeah, it's that simple. Don't come back. We've been doing it like this for 10 years. It works. So you didn't really take into account what my pain points were, because you're the CEO of a big company and you just say, we're going to do this, and it gets done. And you, as much as I tell you, I don't own these companies. I have to ask permission to do these things. I have to have it well thought out. You're like, just do it. And that does not work in my world.
Yeah, but it's your progress note. They're not looking at your progress note. And you were paying for the system anyway, not them.
Yes, but I got to make sure that they're okay with it, George, because it's not my company. They might want you to use the templates and not deviate from the template.
And maybe Herb is part of the 20% that we don't worry about because he's there 1% of the time.
Anyway, so what are your thoughts on it now?
Huh? I think it's still, it's far from perfect.
Yes.
For what I've always thought, so I take a great offense at what you first said, that the doctors were difficult adopters of the urgent care, of the EHR. And this is very political, but this was something that the Obama administration shoved down our throats. They had a carrot and they had a stick. If you do this and you have enough Medicaid patients, we will pay for the implementations. But if you don't do it, we're going to pay you less for the services you do. And it was basically because nobody wanted to use it because it wasn't ready. There's the difference I always tell people is the smartphones, especially Apple phones, nobody gave you an incentive to go buy them. They charge you $1,200 to go get it. And people stood in line to get them because it made sense to them. The EHRs did not make sense to the community. They're nothing more than a cash register, made the physicians a clerk. And it was upside down, dumb idea. Make the most expensive person in your team do the clerical work. And that's why people resisted it. And there's lots of studies that show it did not improve care. It didn't make doctors happier. It didn't make patients felt like we were taking better care of them. The whole is nirvana. We're all going to communicate. Amanda can see my note for the patient in Virginia never came to be. And we wasted billions of dollars that went to the tech industry that were for friends of the administration, like the owner of All Scripts in Chicago that ran the campaign for Illinois for Mr. Obama. And Glenn made multiples of millions with All Script. Okay. So that's why people resisted it. And it was now we're going to have to redo it. And the EHR companies are having a heart attack because with the AI and ambient AI, the whole process is going to go back to what it used to be, a SOAP note, a narrative note. And so now they got 10, 20 years worth of investment in legacy programming that they're going to have to undo to make this better. And it's going to cost them millions of dollars. And guess what? There is no incentives for anybody to go do it because everybody is in a software as a model now. So it's a per month thing per clinician that you're paying, and they don't have the resources to go build it from new again. Some things are too early to market and they fail. And there's lots of examples like that. Who invented the first touchpad? It was Apple. And it was clumsy.
Yeah.
And they took it off the market, and then the Palm Pilot came. And you had to learn another language. I refused to use it. I'm like, I'm going to learn a whole other language to put something into a calendar. I have a calendar in my briefcase. I'll just put it in there. But people love the Palm Pilots, right? So that's what the implementation sometimes fails because the product is not ready for mass marketing.
Yeah. But even with these AI scribes, well, I've demoed about 15 to 20 of these. Okay. I am finding that they are getting more clunky, more complicated, more difficult to use, just like the EHRs, because I think they get some doctor consultant that wants this, and he wants this, and he wants this, and he wants this, and let's add this. If I can't use a product that's out of the box and I just go, I don't want to touch it.
That's right. But that's what I'm saying. A smartphone, you don't need a tutorial. It just works. And the problem with technology is that everybody does that. Like Apple, there's so many things on my laptop I never use. I have no idea. I don't have time to learn them. And they just sit there and they're a waste of time. Simplicity is key for when you're doing a lot of the stuff at the same time. Anyhow, I wanted to ask you, because it's very interesting how we met. We met at a meeting on type 1 diabetes with breakthrough T1D.
Yeah.
And what is it that they're doing? Because I think it's phenomenal work that they're doing.
Yeah, I'm so glad you spoke up at that meeting.
Well, have you ever known me not to speak up?
Not now. No, you're in good company though. Squeaky wheel get the attention. So we met on a work group call with Breakthrough T1D, gathered together some experts who are putting together or now submitted an application to the United States Preventative Services Task Force, or USPSTF, to advocate to add early screening, universal pediatric screening for type 1 diabetes. And to add this into the recommendations, just like you would a mammogram or a colonoscopy. They already have recommendations around type 2 diabetes, around gestational diabetes, pre-diabetes, but there was no recommendations for type 1 diabetes. And so we convened this group of experts to put together this application because we think it's the right time. We think it's ready for prime time for this intervention to come through.
Why do you think this intervention is important? Because I get asked this a lot. Is it because there's a new medication that's very expensive that delays the onset of insulin dependency? And then the other one I get is they're going to need insulin at some point. When they need it, the endocrinologist see it. So why is that? What is the win? Why is the why of that screening early?
Oh, yeah, because we're just pharma shills. So that's really what.
Oh, yeah. I have a Learjet from Sanofi that takes me all over the world for fancy vacations.
No, so I think until type 1 touches you, it's this thing out there that as a clinician you know about, but it's like this really rare, you always think it's like this really rare thing, right? That it's never going to come across, you're never going to see it. But the reality, especially in pediatrics, depending on your population, it's about 1 in every 300 to 500. So every school likely has one type 1 diabetic. Every patient panel is going to have multiple, right? If you've seen 1,000 patients over the last couple months and you haven't seen a type 1, you're not looking hard enough, is the situation, right? If you see 1,000 fevers, one of those is probably going to be cancer, right? So do you want to see that kid? Do you want to diagnose that kid when they're in extremis? Or would it be better to have a screening test and pick it up early? Would you rather have the kid with PKU become completely unable to manage their disease and come in sick, and then you're like, now they're stuck this way, sorry, we could have caught it earlier, but we didn't think it was worthwhile? That's the framework I'm trying to sell this in, is that we have a test that can pick up about 80% of type 1 diabetics. And right now, the screening recommendations are not well adhered to. The screening recommendations for the major academic associations, such as AP or the Endocrine Society, say that any first-degree relative of somebody with type 1 diabetes should be screened. And I can tell you that's not happening. It's not happening. The vast majority of kids who are getting screened via research right now in our country.
What you're talking about is the big win is not pharmaceutical intervention. The big win is prevention of DKA. And
I think so. I think so.
With a DKA diagnosis.
There's about, I know personally of 4 studies that show when a kid presents in DKA, their long-term outcomes are worse than kids who don't present in DKA. And again, I think it's multifactorial. Are the kids who get caught earlier, do they have better connection to care? Do they have better access to care? So, although 3 out of the 4 did a really good job of controlling for socioeconomic inaccess. We're talking about hits on IQ. We're talking about long-term glycemic control. Like, these are real, measurable differences that we can make. And the other big part of this that you mentioned is that now there is an intervention. So we're not talking about, I should be really clear. We're not talking about early diagnosis. Okay, we're not talking about, we are diagnosing the kid because they're coming in and they're sick and we notice, hey, you're spilling sugar in your urine, and then we diagnose them before they're in DKA. I'm not talking about that. I'm talking about years before they develop insulin-dependent diabetes. We can find out that they're at risk, and they have somewhere between an 85 to 100% chance of being insulin dependent in the next 10 years. And so before they ever need insulin, we're able to identify those kids, follow them, and they actually have quite a few different interventions that they can try. Some of them are experimental, some of them are FDA approved. So you're giving these kids a chance at, I don't want to say a normal childhood, but I will say a much decreased burden childhood if you can delay their need for being insulin dependent. It's not as simple as, oh, they just go on insulin and then they're cured. That's easy. It's
a very hard disease.
Not easy.
And I think always every human does better when they have agency. So if I have choices, they may not be good choices. Which one's the one I can swallow the easiest? And giving people choices and being able to be prepared, I think makes a huge difference in the family. And now that he also has a resolution, what is going on with that?
Yeah, so there's timing that's hitting all at once. So even if the USPSTF decides, yes, this is great, we should add this as a preventative service, they're going to kick it over to the P to say, hey, pediatric experts, figure out this recommendation and how do we get this instituted into Bright Futures in the pediatric recommendations. So great timing is there's a resolution going up for vote this summer. The leadership of all the state chapters of all the sections and councils get to hear all the different resolutions that people can bring forward. And they vote to say, which one of these do we think is most important this year to really consider as leadership to then turn around and create public-facing recommendations. So one of the state chapters has also recommended early screening for type 1 diabetes in the general pediatric population. So fairly closely mirroring what's being presented to the USPSTF.
Well, what's been your experience as you talk to leadership? Because you were chair of the section in urgent care at the P, right?
For research, chair of research for the AAP's section of urgent care medicine.
What has been your experience when you talk to other leaders at the AP about this idea, what has been your...
Again, my implementation science brain says, okay, this is going to rock some pediatrician worlds. So the vast majority, you're talking about chapter leaders. So most of them are going to be general practitioner pediatricians, right? That's who's going to be the workforce, not endocrinologists. That has been by far and away the largest misconception or barrier that I faced when talking to different leaders is that's an endocrinologist problem. Let me forward you onto the section of endocrinology. No, you're not understanding. This is going to be general pediatric screening, just like newborn screening, just like anemia, just like lead. It's no different. When those test positive, most of those, especially when it comes to newborn screening, are going to be farmed out to whatever specialist or geneticist, right? Same here. It should just be part of the growing up process and making sure that we're dotting our I's and crossing our T's and not missing anybody. So that's been the largest misconception. I also reached out to the leaders of different sections and chapters that I thought may have interest in this and what their input would be. Again, trying to find out mostly what barriers, but are there any facilitators to seeing this pass? And I think beyond the misconception of this is an endocrine problem was how are we going to get paid for it? How are we possibly going to add this to our plate? And this is going to be, I don't know what to do with it. What if it's positive? What if it's negative? I don't understand the tests. There was this lack of education, which again, we're all smart people. You can figure this out in 5 minutes. It's a one-pager. It's pretty easy. But also knowing that 99% of these are going to be negative. And that's great information too. That's great information. And so I think that we need to not forget about that. Anastasia with Breakthrough T1D made that point in one of our meetings, is that most of these kids are going to be negative, just like a newborn screen. But that doesn't mean that we don't do it.
And even from an implementation lens, this comes up over and over again, especially in primary care. We don't have the knowledge. We don't have the time. We don't have the resources. We don't have the workforce. And that all is real barriers in primary care to doing what we need to do. And there's multiple things. And that's one thing I do like about that AP resolution is that Jesse calls for a CPT code or payment for doing this in the office, because that's necessary. This is a public health measure. And we're asking the private industry to do public health. We need to be paid. Where that money comes from, I don't know, but we need to be paid. It can't be just one more thing that pediatricians do for free or family practitioners, because there really is no time, no money, huge education gap, and there's a shortage of workforce. And in addition to that, what I hear too is people are scared of having a positive kid and having to sit down with the family and say, oh, by the way, your child screened in positive for diabetes. And then people just flip out. What do you mean? When are you going to put them on insulin? No, we're not there yet. Over the lifetime risk is 100%. Your child's going to have diabetes and need insulin at this point because we don't have a cure. So you also have a very personal story, and I wonder if you would share it with us, because I think it informs us of the importance of a mother's intuition and how it is important not to dismiss that in the exam room. What's your story?
Part of it is, how is this pediatric urgent care doc so passionate about early screening for type 1 diabetes? And you talked about Dr. Tu having a diabetologist certification. And really what happened was, again, I was researching, I was administrating, I was clinicianing, a very busy mom. It was during COVID. And my youngest son was having just major behavioral issues, like getting kicked out of preschools for biting and flying off the handle. And I thought, oh my gosh, is this some sort of trauma response? Everybody's in masks. We've moved 4 times in the 4 years he's been alive. What have I done to my child type of thing? And my husband and I sat down, and when honestly I wasn't given FMLA to address it, I left largely my position and spent 3 months doing intensive therapies with him. And I thought maybe it's getting a little bit better, but there is still something here. There's still something that's just not sitting right. And we were taking a train ride to go pick up his older brother from his grandparents, and he peed 10 times on that 4-hour train ride. And the light bulb went off. And I thought, oh, you have type 1 diabetes.
Oh, wow.
That's what this is. And then everything's flooding back. Like, the bedwetting is not like a behavioral thing. The falling asleep after dinner, the highs and lows, the misbehaving every time the grandparents came and brought treats. Everything was falling into place. And luckily he wasn't an extremis, although I imagine his blood sugar was pretty high after drinking juice and having treats on the train ride there. But we went home. I called my husband, who's in medicine, and like his normal response, anytime I diagnose something, he's, get out of here. That's not what this is. And I'm like, oh, don't trust me, the pediatric urgent care doc. This is only my job.
Anesthesiologists don't diagnose anything.
I diagnosed him when he had a ruptured appendix, and he didn't believe me, and he sat on that for 3 days as well. So let's just level set of where ability to deny comes in.
So he's more stubborn than George. Oh my God.
Yeah, so we took him to his pediatrician, which to their credit, I called them and I was like, yeah, I need to schedule their well child. I think he's got type 1 diabetes. They're like, no, you don't schedule that. You come to the office. I was comfortable with what was going on. I knew he wasn't an extremis. We eat a fairly low carb lifestyle here anyway. And so I actually had taken him to get his COVID shot, his second COVID shot, and run into a really good clinician friend of mine who happens to be an endocrinologist, and said, hey, will you check? He's got orders for labs. Will you check and just make sure everything's right? He's got labs for what? And I said, oh, I think he's got type 1 diabetes. He's like, that's a bold statement. And he calls me that. Oh my gosh, I'm so sorry. I saw
it. Ryan? This is Ryan? Who is this? Was this Ryan or?
Yeah, this is Ryan.
And if you don't know Ryan, you don't understand. He's the funniest man on earth. And you can't help but fall in love with him after you talk to him for 10 minutes.
Yeah. We've been colleagues for over a decade, and he's just a joy to be around. And he called me that night. He's, oh my gosh, I am so sorry. What can I do to help? And I said, you can help me with this Lantus, because I've ordered it, but I've never given it before. And he's, what do you mean? Why aren't you in urgent care? Because we developed this program in our urgent care where for new diagnoses that aren't in DKA, we'll give them their first shot of Lantus, and then we'll send them home to follow up in clinic the next day. The endo on call was like, oh, Amanda's got this. I'll just order it to the pharmacy and we'll follow up in clinic the next day. So I show up to the pharmacy, all the supplies are laid out. I have the Lantus there, and I'm like, I don't see pen needles. Don't you need needles to get the Lantus from the pen into the body? And the tech was like, yeah. And I'm like, okay, can I buy one of those? And she's, oh no, you don't want to do that. That's really expensive. I'm like, can I write a script for it? Are you a doctor? Turns out I am. Never wrote a prescription for a box of pen needles before, but 1 box pen needles got the job done. And Ryan's just FaceTime me. We'll figure it out. And I learned you have to prime the needle, and yeah, so it was fine. We got him started. We got our training, and he's doing really well. So
I'm glad he's
our
doing
personal type 1 diabetes story.
And so you did it all as outpatient.
We did everything as outpatient.
Never spent the night in the hospital.
He's never been in the ER. He's never been in the urgent care for anything diabetes related. We've never had to be inpatient. So we've been really lucky. I do what I do with anything when I'm learning it new. I went to the literature and went and read all the research I could get my hands on. I went out and met all the key opinion leaders, which is how I ended up, I think, in that group with Breakthrough T1D, because I've talked to just about everybody there. And then I was like, everything 24/7 in my life is type 1 diabetes. I should probably have something that recognizes that I am an expert in this. So I went ahead and sat for my boards. So I'm board
Good for
certified in
you.
advanced diabetes management as well.
Great for you. And then so he's doing great. I'm so happy he's doing great.
He
And
is. He's
if I may ask, because I'm curious, did you screen yourself and your husband and the other kids?
That's a great question. We tried really, obviously, I love research. We wanted to participate in anything we could. We tried really hard to get into TrialNet and couldn't make it happen. Like the implementation of that here wasn't well oiled. And so finally, when our kid's next child check, I just told our pediatrician, hey, I want to screen my oldest. I don't know how to do that. I'm like, don't worry. Here's the 4 tests you need to order, and insurance paid for it. So my husband and I have not been screened. My husband's father has been a diabetic as long as my husband can remember. They always assumed it was type 2 because he got diagnosed at 40. But I have a suspicion that he actually had LADA and had latent adult diabetes, diabetes of adults, and because he was on insulin within months of his diagnosis.
40% are misdiagnosed. So it's thank you so much for sharing that. And diabetes is such a hard disease in the families. And this is one of the best outcomes. You never spent the night in the hospital. And
Yeah.
that's really, other than giving families the cure, which would be a dream for me, is making the landing easier so that it's not a PICU admission. Your kid's got cerebral edema. If he survived, he's going to have to give shots to himself for the rest of his life. And you can't leave him alone. And you have to have a buddy with him in college. And you got to do this and you got to do that. But we can't offer the cure right now. But if we can just offer a soft landing.
Yeah.
Just from the human, not the better glycemic control, not the avoidance of IQ and EQ damage, not the 3 in 1,000 mortality rate of decay, just the human side of not having to be in the hospital while you're trying to understand why your child has to go through this.
Yeah. Yeah.
I think that's
Having to learn how to keep your child alive while being in a state of shock. I can't fathom. Our family has every advantage under the sun. I am fully aware of that. And it is still difficult to function as an external pancreas for another individual.
Yeah. Yeah.
And it is extremely challenging. And how families who are diagnosed in extremis, who have to take in all this information via fire hose while sitting in an ICU room, I couldn't imagine. Unfortunately, I can't imagine, but my hope is that we decrease that by 85, 90%.
Yeah. That would be great. George, do you have any more questions before?
No,
A lot of them ain't
very good. We're very good. I think we reached the top of the hour or hour and a half.
I'll have to have you back and tell me what you're doing through your consulting company. I'm interested in that.
Do another podcast on that one.
Yeah, but thank you for your time, and it's always a pleasure to see you. But this has been a phenomenal episode.
Yeah, I'm so glad we met.
Yes, if you believe in God, I think sometimes God puts you in the right place at the right time.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.